I'll be introducing you to the concept of health beliefs and different models of health beliefs, as well as behavior change. One of the difficult aspects of a pharmacist practice is caring for patients who struggle with adherence to treatment recommendations. Beyond developing optimal therapeutic regimens for patients, the role of the pharmacist includes motivating patients to adhere to their regimens so they can receive optimal therapeutic benefits. When confronted with non-adherence, a pharmacist must consider and investigate the reasons why a patient is not following health directions. It often is assumed the patient unintentionally does not follow directions. Although this does occur, unintentional non-adherence is not always the explanation. Sometimes a patient intentionally does not take a medication or adopt a healthy behavior. It is important for the pharmacist to consider all the possibilities or factors influencing patient behaviors. In 2003, the World Health Organization released a report compiling information about adherence in both developed and undeveloped countries. The report also reviewed literature on adherence in patients with a variety of disease states. In the report, factors influencing patient adherence to recommendations were divided into 5 areas or dimensions: health system, social economic, condition-related, patient-related, and therapy-related. Although not all items affecting adherence were discussed, the report provides a framework to classify adherence issues and allows pharmacists to recognize that adherence is affected by factors other than simply remembering to take a medication. Condition and therapy-related factors are items that many would expect to see on the list. For example, increased frequency or complexity of the regimen results in lower adherence. The frequency and severity of adverse effects can also result in lower adherence. Demographic factors such as sex, age are commonly assumed to influence adherence, but evidence is inconsistent in supporting these assumptions. Taking into account the list of factors listed on the previous slide, effective programs need to extend past the simple provision of information. The patient-related factors that influence whether individuals adopt healthy lifestyles or adhere to medication recommendations cannot be adequately addressed by patient education alone. To result in behavior change, components of effective interventions or programs include information, development of self-management skills, development of self-efficacy, and social support for encouraging maintenance of changed behaviors. Several models have been studied and applied to assist pharmacists in understanding patient success or lack of success in changing health behaviors. These models have been used to help explain a variety of health behaviors, including preventative behaviors such as attending health screenings, taking multivitamins, using contraceptives, and using sunscreen. These models also are used to explain patient behaviors in the management of chronic conditions such as congestive heart failure, arthritis, hypertension, and diabetes. I'm going to describe some different health behavior theories on the next few slides that can be used to help health professionals facilitate behavior change in their patients. I want to make a note that this is not a comprehensive overview of all existing health behavior models, but I'm going to talk about the most common models reported in the literature. Social cognitive theory relates to the performance of a behavior change to an individual's expectation of or his or her ability. Social cognitive theory relates to the performance of a behavior change to an individual's expectation of his or her ability and the probability of success in accomplishing the change. In this model, there are 2 types of expectations: outcome and efficacy. Outcome expectations refer to an individual's belief that performance of a specific task or behavior will lead to a specific outcome. Efficacy expectations refer to the patient's belief that he or she has the ability to perform the behavior change. To maximize the possibility of behavior change, a patient needs to have both high outcome and efficacy expectations. Here's an example of some of the concepts that are included in the social cognitive theory, their definitions, and potential change strategies. So as you can see here, this concept of reciprocal determinism is the dynamic interaction of the person, behavior, and the environment in which the behavior is performed. So in order to promote behavior change, you need to consider all of these different possible influences or factors. Behavioral capabilities, so the knowledge and skill to perform a given behavior. So for instance, a potential change strategy would be promote mastery learning through skills training. Expectations, anticipated outcomes of a behavior. So we're going to model positive outcomes of healthful behavior. Self-efficacy, the confidence of one's ability to take action and overcome barriers. Observational learning, so behavioral acquisition that occurs by watching the actions and outcomes of other behaviors, so having good role models. Reinforcements, responses to a person's behavior that increase or decrease the likelihood of reoccurrence. So rewards and incentives are really great at promoting behavior change and maintenance of behavior. This is taking that previous table and kind of putting it more into a diagram here that shows you how these three different factors can influence each other and what might be the concepts related to each of those factors. The health belief model is one of the oldest models used to explain behaviors. This is this figure is a graphical kind of representation or a diagram representing how these factors might influence one another and the concepts or things that might be playing into how this slide is just taking the previous table and showing you the relationship between these different factors and concepts. One of the main goals of pharmacists assisting patients in behavior change should be to identify ways to improve their self-efficacy. Patients' perceptions of their abilities to accomplish tasks or behaviors influence their adherence to drugs and lifestyle modifications. The health belief model is one of the oldest models used to explain patient behaviors. The basis of the model involves the desire to avoid illness or to get well, and the belief that a specific action will prevent the illness or lead to wellness. So here, like in the social cognitive theory, I've got columns to describe the concepts of the health belief model, the definition, and potential change strategies. So in this model, individuals determine their threat or risk of an adverse health event by evaluating their susceptibility to the disease or the severity of its consequences. This evaluation of the disease threat or health event influences the likelihood of taking action or changing behaviors. Perceived susceptibility refers to a patient's belief of whether the disease is likely to occur or the vulnerability of a patient to a disease. The perceived severity, or how bad is it, is evaluated by the patients with regard to the seriousness of the consequences of the threat. If both perceived susceptibility and severity are high, the individual believes the disease can occur and is serious, therefore increasing the likelihood of taking action or changing a behavior. If either of these components is low, then the likelihood of change is lower. The health belief model also suggests that other factors influence the likelihood of patients taking action to improve health. These include these include the perceived benefits and barriers of the behavior change. Patients weigh the benefits and barriers and then determine if they will attempt the change. For the benefits, patients consider the effectiveness of the change in reducing the threat of the disease or specific health event. Patients also evaluate the negative aspects or barriers of the behavior change. If the benefits outweigh the barriers, change is more likely to occur. If perceived barriers are more significant than perceived benefits, the likelihood of change is lower. When barriers outweigh benefits, patients are less likely to take action, even if they have both high perceived susceptibility and severity. Cues to action also can influence a patient's perceived threat of disease. These are stimuli that can change a patient's previous perception of the threat. Cues can include a mass media campaign about the disease, a family member or friend receiving a diagnosis of the disease, or a celebrity developing and discussing the disease. When a cue occurs, it can trigger the decision-making process for a patient. Modifying factors are often included in the model because they can influence the patient perceptions. Modifying factors, like you can see here in this model, might be things like age, sex, ethnicity, personality, socioeconomics, knowledge, or prior contact with the disease variables. Here's an example of the health belief model application to testicular self-examination. So for the first concept, perceived susceptibility, this is an example of a measurement of perceived susceptibility. So the patient says, my chances of getting testicular cancer are great if I fail to perform testicular self-examination. Perceived severity, the thought of testicular cancer scares me. Some potential perceived benefits, I have a lot to gain by doing testicular self-examination. Perceived barrier, testicular self-examinations can be painful. What are some cues to action? Maybe campaigns promoted to do testicular self-examinations. Maybe even symptoms like soreness, size, shape change prompted the patient to do testicular self-examination. And then self-efficacy. If you're going to do testicular self-examination, how easy is it for you to do it correctly? Okay, the transtheoretical model of change, often called the stages of change or readiness to change, identifies patients' readiness to change their behavior. Identifying a patient's level of readiness to change helps determine the approach that should be used to motivate change. Patients are classified into one of 5 stages: pre-contemplation, contemplation, preparation, action, or maintenance, according to their level of motivational or behavioral readiness in committing to a change. The basic premise of the model is to help patients move one stage forward in the continuum, not directly to action. Patients must move sequentially through the stages for change to occur. Approaches or interventions should be targeted on the basis of a patient's level of readiness for change. In the pre-contemplation stage, patients are not considering or contemplating a change in the next 6 months. There could be a variety of reasons why they are not contemplating a change. For instance, they are unwilling, they are uninformed, or do not recognize the need to change, or they are discouraged or have tried to change previously but have been unsuccessful. This would be an example of low self-efficacy. In the contemplation stage, patients are considering a behavior change within the next 6 months. Unlike pre-contemplation, patients are aware of the need for a change at this stage. However, the barriers of the behavior change outweigh the motivating factors, resulting in ambivalence to the change. When the patients move into the preparation stage, they are beginning to take steps to implement their behavior change in the short term, often characterized as the next 30 days. They are investigating their options or alternatives, such as identifying diets, gathering support, joining a gym, or buying tobacco cessation products. When patients are consistently engaged in the target behavior, they are in the action stage, which lasts about 6 months. When patients have actively been engaged in their changed behavior for more than 6 months, they are in the maintenance stage. Other components included in the model are decisional balance, self-efficacy, and process of change. Decisional balance involves the patient weighing the pros and cons of the behavior change. This is explicitly seen during the contemplation and preparation stages of the model. However, it can occur in other stages as well. As people progress through the model, the influence of the pros for the behavior change increases, whereas the influence of the cons decreases. Self-efficacy is, as we described earlier, the confidence of individuals in their ability to perform the behavior change. In many studies, higher self-efficacy often indicates that a patient is in the action or maintenance stage. Processes of change will be described in the next video. The transtheoretical model has been applied in a wide range of disease states that require health behavior changes. For instance, smoking cessation, weight loss, and exercise. Patients can fluctuate between stages, including relapses during the action and maintenance stages. In addition, individuals can get stuck in a particular stage for long periods. The goal of the pharmacist is to help patients decide to move through the stages until they reach action and ultimately maintenance. The first step in the process for the pharmacist is to determine the stage or level of readiness for individuals. The staging algorithm is a discrete categoric measure identifying one prevailing stage. It is more commonly used than other measures because it is brief and can be verbalized as a question or series of questions in a patient encounter. Using smoking as an example, the pharmacist can ask patients, "Are you currently a smoker?" The patient's response possibilities are as follows. 1, yes, I currently smoke, so that could be pre-contemplation, contemplation, or preparation. 2, no, I quit within the past 6 months. This could represent action. Or 3, no, I quit more than 6 months ago. This could represent that they're in the maintenance stage. If patients say they smoke, the pharmacist then asks a follow-up question. Are you seriously thinking about quitting? Patients are then staged as in the pre-contemplation, contemplation, or preparation based on whether they planned on quitting and the time frame for the change. For example, if patients say they plan to quit within 6 months, they are in the contemplation stage of the change. Once the stage of readiness has been identified, the pharmacist can determine the techniques to facilitate movement through the model. In general, the approaches used for the pre-contemplation and contemplation stages are quite different from those used in the other stages of the model. These approaches or techniques will be discussed in greater detail in the next video. There are commonalities among the models that increase the likelihood of a patient changing behavior to improve health. These commonalities include patients' beliefs about having the requisite skills, facing few barriers to the change, achieving a positive outcome from the change, and having a support system for the change. In addition, patients must be motivated to change the behavior and must be confident about their ability to perform the new behavior. When using these models, remember that they are based on the patient's perceptions, not the pharmacist's. Although the pharmacist can believe the patient has the knowledge, confidence, and capability of performing these changes, if the patient does not view the situation the same way, change will not occur. Like I said at the beginning, these models are only a few of the many in the literature. Reviewing a variety of models can assist pharmacists in determining the best theoretical approach for facilitating behavior change in patients. The goal of pharmacists is to determine the issues preventing a patient from changing. Approaches to facilitate patient behavior change should be based on an evaluation of the individual patient's needs. Provision of patient education will not necessarily help a patient if low confidence is preventing a behavior change. This is the end of the video.